Okay, Fiona, you can take it away.
Okay. Um, Hello, everybody. Thanks so much for coming today. I'm going to be talking about two projects that I've spent the last several weeks developing. And the first one is a project about water, which I've decided to call Tapping In, Assessing Water Quality in Household Filtration Solutions in Ecuador. But first, I want to share a little bit of information about myself. So my name's Fiona Wolter, and I'm from Little Rock, Arkansas. I'm a rising junior at Princeton University studying ecology and evolutionary biology, and I also plan to get a minor in environmental studies. And in terms of my why I decided to do this internship, I knew a couple of Princeton students who participated last summer and had a really positive experience, which first introduced me to the program. But it also really aligned with all of my different interests. I wanted to improve my Spanish, gain clinical exposure as someone interested in medicine, and explore my interest in environmental health, particularly water sanitation, as well as women's and children's health and nutrition. And I'm so grateful that I've had the opportunity to explore all of these avenues in one way or another over the past 2 months. So, going back to the water project, I want to briefly go over the work of the previous interns on this topic to give some context for where the project stood before I arrived. So, back in 2019, Isabel evaluated different water purification technologies and assessed the feasibility of implementing them in a community given Patches and Phoebus existing resources. Then, in 2022, 3 interns developed a proposal for the community of Caliata centered on a gravity-fed rainwater system or groundwater system, along with agroecology recommendations for a community garden and farmers collective to support indigenous agriculture. And lastly, in 2025, Catherine reviewed water-related illnesses in Ecuador through both a literature review and ethnographic research. She also met with the community of Lan to gather information about its gravity-fed water system, which was installed in 2000 with support from another nonprofit in the area called World Vision International. Once I reviewed the previous work, I was able to build on it and develop my own project. So this slide gives a quick overview of that process. I first expanded Catherine's literature review into a more comprehensive annotated bibliography on water quality and waterborne diseases in Ecuador. I also adopted her survey and, with the help of Phoebus staff, collected more patient responses. I had the opportunity to revisit the community of Lan and meet with the president of its water board. One of my motivations was to see if filtration technology would be useful for this community, but their distribution and treatment system is luckily functioning well. They are able to drink water straight from the tap and have not experienced any reported cases of waterborne diseases. I then spent time updating Isabel's work by researching current water treatment technologies. I found a WHO report from March of this year about household treatments especially helpful for this part of my project. And lastly, I used all of that information that I compiled to create an implementation plan of how Phoebus could, over the course of the next 2 years, actually distribute filters to a local community while also providing critical education about wash measures or water sanitation and hygiene. One important finding from my literature review was that water management in Ecuador is highly fragmented and dynamic. While the national government sets regulations, provincial and local governments manage drinking water and irrigation, leading to a decentralized system with large differences in water quality across regions. This is especially true in rural areas, which have an estimated 7,000 community water service providers. Many of the rural communities rely on juntas del agua, or water users associations, which are community-run organizations that manage local water systems. They're composed of both the water treatment and distribution infrastructure itself, as well as a management committee. These organizations often depend on a minga, which comes from the Quechua word minca, meaning performing work for the common good. Community members help build and maintain water systems in exchange for free access and a voice in decision-making about the issue of water management. Of note, however, the minga as a social structure reflects a culture of shared responsibility that extends beyond water practices alone. And with this fragmented management system comes important gaps in water infrastructure and quality, particularly in rural and indigenous communities. A joint WHO and UNICEF monitoring program surveyed households across Ecuador in 2016 and 2019 to measure access to safely manage drinking water, which considers water quality, accessibility, availability, and coming from an improved source that must be protected from contamination. You can see the results of this study in the graph on the left. Nationally, about 70% of households met this standard for both years, but there was a 28% point gap between urban and rural areas. The biggest barrier to safely manage drinking water was poor water quality, indicated by E. coli contamination. Another study that's relevant to this idea was published by the local University of Espooch in 2022. Researchers tested water in the rural Chimborazo community of Iran and found that although the physical and chemical metrics were generally within acceptable parameters, all sampling sites exceeded the safe limits for total and fecal coliform bacteria. An ENEC report from 2018 found that only about 21% of Indigenous children have adequate wash access, meaning the vast majority do not simultaneously meet international standards for water, sanitation, and hygiene. Another surprising finding from this research had to do with boiling, which is a common strategy for treating water at the household level. Of note, boiling practices are often based on perceived water quality rather than actual contamination. So there's not a big difference in boiling rates for regions with contaminated and uncontaminated source water. And according to the nationwide surveys from 2016 and 2019, even among households with contaminated source water that reported boiling it, only about 28% had E. coli-free water at the point of consumption, suggesting insufficient heating or unsanitary storage practices. And jumping off of that point is a list of prevalent human activities in Ecuador that can negatively impact water quality. One is crude oil production and mining, particularly artisanal and small-scale gold mining, or ASGM. Both industries have expanded in recent years, and oil spills and toxic byproducts from mining can contaminate waterways. Agriculture is another contributor, with pesticide, fertilizer, and livestock runoff all impacting water quality. And as I just mentioned, household practices matter, as safe storage practices are essential to preventing water quality concerns. In addition, infrastructure gaps have led some communities to discharge untreated sewage into rivers and streams, including in the capital city of Quito. Lastly, I do also want to note that water quality can be influenced by natural factors, and for Ecuador in particular, volcanoes and periodic seismic activity can influence its water quality. These water quality challenges have important public health consequences, which is reflected in the waterborne disease rates. Looking at these rates also gives us insights into the types of microbial contaminants in the water, since some diseases are caused by bacteria, while others are caused by viruses or protozoa. One key finding for the work of FIVUSPAM is that, according to nationwide hospital data from 2011 to 2020, Morona Santiago has the highest hospitalization rate for waterborne diseases of any province, at 446 cases per 100,000 inhabitants. Chimborazo also had a substantial burden, with about 300 cases per 100,000 people. The same hospital data also showed that Indigenous populations experienced the highest waterborne disease burden and mortality rates. Although Ecuador has relatively low diarrheal mortality compared to the rest of Latin America, these disparities remain significant. And one disease that I wanted to highlight was hepatitis A. As you can see in the map, recent Ministry of Health data from 2025 showed relatively high case numbers in both Chimborazo and especially Morona Santiago. This viral disease is a big problem in the Amazon, as case studies of Shuar communities have found that nearly the entire population tested positive for antibodies of the virus, and 100% of people by age 6, indicating that everyone by age 6 had at least one infection of hepatitis A. Overall, there's a lot more data on this topic, but I hope that these findings highlight the need for stronger rural infrastructure, improved household hygiene and storage practices, and treatment technologies capable of removing both bacterial and viral pathogens from contaminated waters. And now we're going to go into the survey phase of my project. I'm not sure why one of my visuals is for the speech bubble is looking a little weird. The contaminants, so apologies for that. As I mentioned before, Catherine developed patient and provider surveys and conducted interviews directly at the hospital. With the help of FEBUSBAM's general medicine doctor, Dr. Rodrigo, I was able to distribute the patient survey more broadly and collect another 80 responses. While most respondents were from urban areas, combining Catherine and I's results gave us 29 responses from rural residents. So I took this data, cleaned it in Google Sheets, and then made some graphs visualizing it with R. The comments in the speech blurbs on the right represent some qualitative themes from the responses. One participant asked whether boiled water or potable water is better. Generally, the answer is potable water, since although boiling when done correctly deactivates microbes, my previous statistics show that it's often not done properly, and it cannot remove chemicals, heavy metals, or microplastic pollutants from the water. More importantly, however, the question points to a larger need for education around these topics. Another concern, the failure to understand diseases, points to the same education gap. And this concern is validated by the fact that one survey participant noted hepatitis B as a waterborne disease that they treated for, but this is actually not waterborne. Finally, one participant expressed concern about excess chlorine affecting water taste and smell. While chlorine is often a useful disinfectant, this reflects broader concerns about the consistency and quality of water treatment practices in some communities. And now, for some more quantitative data, the majority, specifically 20 of 29 rural respondents, definitively knew someone affected by a waterborne disease. For context, 5 of the responses were unclear, meaning only 4 participants reported no known cases. Many respondents also reported buying bottled water for drinking. In terms of water sources, most got their drinking water at home, but about a third still depended on community sources. Nearly all believed that their community or government could take measures to improve water quality, with the most common suggestions being education campaigns and improved treatment practices. The graph on the right is one example of the visualizations that I made with R. It shows the reported duration of waterborne illnesses, and most lasted for 2 to 5 days, but several had some, but there were a few that had experienced symptoms for longer than that, with 2 actually lasting over 21 days. In fact, the longest duration reported was 60 days, highlighting the potential severity of these illnesses. The third and perhaps most exciting component of this project was identifying concrete solutions. One distinction that Isabel's work highlighted was the difference between point-of-use and community-based water treatment technologies. Point-of-use options treat water at the household level where it's consumed, while community-based systems are often more technologically comprehensive and treat water at a shared source or distribution point for the entire community. So the past interns that planned the gravity-fed system in Caliata were developing a community-based model. However, for a future patch water technology project in a rural area, I decided it would be more feasible to opt for a point-of-use solution. One of the reasons for this is that I did not have a specific community in mind to work with, making it harder to plan a highly technical and localized infrastructure. This makes point-of-use options more adaptable across communities. They also have lower upfront costs and can be implemented almost immediately, making them easier to pilot, potentially through a medical caravan format. Still, it must be emphasized that point-of-use solutions need to be locally relevant. The WHO has found that household treatment options can reduce diarrheal disease risk by up to 41%, but success depends on selecting appropriate technology for particular contaminants and ensuring consistent use among community members. The WHO has an ongoing program called the SCHEME, which evaluates household water treatment technologies based on microbial removal performance and assigns them a 0 to 3-star rating, with 3 stars being the highest. A report published this March reviewed major point-of-use technologies and summarized results from 51 different products. There are a lot of different kinds of technologies that you can opt for, but I found the most feasible options to be membrane and ceramic filtration systems. Both use size exclusion to remove contaminants and can treat water fairly quickly without electricity or chemical inputs. I then researched pricing and quickly identified funding as a major challenge, since most filters cost at least $50 per unit. To address this, I compiled a list of promising options and reached out to the companies to explore bulk pricing opportunities. Luckily, one company responded. Gil Griffith from the Griffith Family Filters emailed that due to a decline in aid funding, their company has an excess stock in their factory and offered the family filters to patch for £20 each, which comes out to about 27 US dollars. For context, they normally cost $150. This filter has a 3-star WHO classification, meaning it's at the highest performance level for removing all 3 types of microbial contaminants. It can attach to standard buckets or vessels, can pump 2 liters per minute, and has a long lifespan. Maintenance is typical for membrane filters, requiring regular flushing as well as pre-filter and seal care, but its built-in back flushing and purging filters simplify this process. Overall, I'm excited about the potential to implement this filter in a community, but several steps need to happen first, which brings me to my implementation plan. The final part of my project was creating an implementation plan outlining all the steps FEBUSBAM would need to take to successfully distribute filtration technology to a rural community. My working title for this initiative is the Rural Water Filtration and Wash Education Program. I divided this plan into 3 phases. Phase 1, taking place this year, focuses on identifying a partnering community, assessing their water quality needs, developing a budget, securing funding, and purchasing the filters. Phase 2, planned for next summer, involves creating educational materials on filter use, maintenance, and broader wash practices or water sanitation and hygiene, followed by a community workshop to distribute the filters and resources. Phase 3, happening the following summer, would evaluate the program's impact. This entails assessing filter use, community experiences, and lessons learned to guide future work. In terms of immediate next steps, Zach will oversee the continuation of this project and help move the implementation plan forward. However, having a patch fellow or FEBUSBAM staff member on the ground this year will be a valuable resource for building a partnership in a rural community. Along with that, the 2 biggest priorities for this project to get this project off the ground are securing funding and establishing the community partnership. Additional considerations include continuing surveys and data analysis to strengthen donor support, as well as partnering with a SPOACH or a local water quality testing facility to test and better understand the specific contaminants affecting the selected community. So because I use a lot of different sources during this section of my presentation, I wanted to provide my references. And now I'm going to shift gears and talk about my other project I worked on this summer, which I'm calling Programa Madres, What Comes Next, a review of past cohorts, current resources, and future recommendations. So I'm going to start with a brief overview of this program, which has been called both Programa Madres and Project Prosperity. Its mission is to support adolescent mothers and their families through structured cohort programming. The program has used 2 different cohort models since it started in 2021. The first focused on technology and entrepreneurship, while the most recent model emphasized artisan skills and mental health. There have also been 2 recent projects about this program. Last summer, Evelyn interviewed 14 women from the original technology cohorts about their experiences and barriers that they had in the cohort. And then she developed a SWOT analysis and recommendations for the future. SWOT stands for strengths, weaknesses, opportunities, and threats. And the image on the right is actually a screenshot from her presentation about this analysis. Then, in the spring, a graduate student named Faith conducted a feasibility study for the new cohort model, for a new cohort model called Women's Health Certificate Curriculum. So the first step of my project was reviewing some of this past intern materials to get an understanding of how these cohorts worked. The original cohorts ran in 2021 and 2022, recruiting young mothers in the region for 4 weeks of Saturday programming focused on digital and entrepreneurial skills. Participants were tasked with developing business plans, and many created businesses around handmade traditional clothing and accessories. Those who completed the program received a free computer to continue using afterward. Evelyn's interviews highlighted several strengths, including 100% participant satisfaction, a strong sense of community among the participants, and access to several critical support services. However, participants also faced challenges, including difficulty launching their businesses due to startup costs, transportation and childcare barriers, and communication issues through WhatsApp. After the program ended, another challenge emerged. The original lesson plans, which were created by a private consultant, were no longer available. And now I want to talk about the most recent cohort, which has been an initiative spearheaded by Amelia Haymatch, a women's health fellow who just completed her year at FEBUSBAM. Since November 2025, Amelia has hosted monthly meetings based on topics requested by the mothers, including mental health, felting, and sewing projects. She also developed partnerships with Dr. Moyo, a Phoebus-Bam psychiatrist, and with sewing instructors at EFAL Academy to facilitate these workshops. However, without dedicated grant funding, she's faced challenges with the scope of her programming. Additionally, a major challenge has been inconsistent attendance, with only 2 to 10 participants per workshop and 3 regular attendees, despite free childcare and lunch. Compared with the previous technology cohort, these meetings lack a time-bound structure and a tangible incentive like the computers provided at completion. Another barrier includes transportation challenges, especially mothers from Colta who've had issues with both communicating and getting transports from where they live to Phoebus-Bam. Also, there's been general communication difficulties with these mothers, and 2 of them have had their phones stolen during this cohort cycle. Another component of my work has been analyzing Faith's proposal. Faith's model consists of 8 consecutive weekly workshops covering different health and parenting topics. Key strengths include a clear, time-bound structure and a comprehensive introduction to important concepts. She also mentioned developing a cohort dataset to publish for future studies. This seems like a promising idea, since Evelyn discussed a major challenge being the lack of up-to-date research on the effectiveness of programming for adolescent mothers. Data can also help motivate future fundraising efforts. My understanding is that she wanted to have exams each week and use that as data, but I think an initial and final knowledge check, along with longer-term follow-ups, would better capture the outcomes we're hoping to measure. And that brings us to some of the areas I've identified for improvement. Faith proposed teaching computer skills at the first session and distributing computers afterward, but I think computers would be more effective as a completion incentive, and digital skills would require a more dedicated instruction than just one meeting. Additionally, the proposed curriculum lacked local input, a clear funding stream, and a data privacy plan, which would be necessary if there were an intent to publish a cohort dataset. Through my review of Programa Madres, I felt the biggest priority should be creating a long-term, sustainable program through an adaptive and reusable curriculum. Making such a curriculum requires resources, so I did an assessment identifying the resources that the hospital already has and gaps that need to be addressed. Phoebus-Bam currently has 7 computers and an interest in restarting a technology cohort. Amelia also secured discounted access to up to 20 additional computers through a nonprofit called Close the Gap, though additional funding is still needed. The hospital can build on existing resources in nutrition and mental health as well, which have been created by recent and ongoing projects. Recent partnerships with Phoebus-Bam's clinical psychiatrist, Dr. Muyo, can also support mental health programming. Lastly, in terms of sewing, Phoebus-Bam has 12 sewing machines and an ongoing partnership with EFAL instructors to guide sewing workshops. Still, major gaps remain, including a lack of finalized lesson plans, inconsistent funding, unlimited staffing continuity, as much of the program's recent development has relied on short-term interns and fellows. So as I just mentioned, I believe program sustainability should be prioritized in developing this program for the future. There's a lot of different potential focus areas that a curriculum could center around. And while I do think that some of these can be combined, the first step would be defining what we want this program to be about. During our most recent medical caravana with Project Nido, we offered health and beauty services to Programa Madres participants and other young mothers in the area. I was able to talk to some of these women about what topics would be most useful for them, and they emphasize parenting, education, and job support. But I would recommend more conversations with these groups, along with the resource assessment, to really narrow down Phoebus-Bam's priorities. Alongside and building from that step, another critical action would be securing additional grant funding so we can expand the impact of this program, as well as creating the curriculum either with the help of a consultant or by adapting existing materials. Then, once the next cohort is ready to be launched, recruiting participants through entrance interviews would be advisable, since such interviews could be a good way to collect background information, confirm contact info, identify additional support needs, and build stronger cohort structure to encourage attendance. Overall, This summer has been such a meaningful experience for me. My presentation hasn't really even touched on the special moments outside of my project work, like shadowing doctors in the hospital, assisting in the medical caravans, and sharing meals with my homestay family. Looking back, two major takeaways stand out to me. First, my perspective on community engaged work has evolved. Princeton really emphasizes the importance of service. Their unofficial motto is in the nation's service and the service of humanity, and I've spent a lot of my time there thinking over the dimensions of this kind of service-based work. However, this internship deepened my perspective on the kinds of critical relationship building that must happen when partnering with communities. Zach emphasized communities' roles as partners and experts in their own experiences rather than beneficiaries. That reinforced the importance of co creation, meaning defining problems and solutions together, and show me that meaningful global health work depends on local ownership, listening, and collaboration. It helps me realize that you don't have to arrive with all the answers or any answers at all to contribute meaningfully to a project. My second takeaway was the value of embracing new challenges. Although I don't have, although I do enjoy stepping out of my comfort zone, I've never really had experiences living abroad before, and I only began learning Spanish at Princeton. I arrived nervous about communicating in Spanish, but I sought out opportunities with native speakers and especially the support, and especially sought out conversations with my homestay family. And with their support, I've gained both conversational skills and confidence in my communication abilities. Adapting to a new language, culture, and way of life really pushed me to grow not only as a student, but a person at large. And lastly, I just want to take some time to give some acknowledgement to all the lovely people that made this internship possible, including Zachary Smith, Amelia Haymatch, Dr. Corey Palmacaro, Rosario Guacho, Mariela Diaz, Pomo Palmacaro, and all the staff at VivaSpam and Patch. Additionally, I'm so grateful for all the Patch interns, especially my homestay sister, Ann Henricks, for making the summer so memorable. And that's it. Thank you. Oh, wait, I do have questions.